Appreciate the opportunity to talk to you this afternoon. Arlene Wohlgemuth, Texas Public Policy Foundation, testifying against House Bill 3791. I really hate testifying against this bill because there is so much about this bill that I appreciate. It points to a block grant, and I'll talk more about that in just a moment. It attempts to get to a private market solution. It talks about premium assistance rather than entitlement. It proclaims that it is not an entitlement. It strives to achieve being cost neutral to the state, utilizing the premium tax. It implements cost sharing, which we feel very strongly about, and it points to health savings accounts, which we also think should be implemented wherever possible because it has had such remarkable results in saving money and in providing additional choices to the people covered by them. My discomfort with the bill, however, is that while it proclaims to not be Medicaid expansion and proclaims to not be an entitlement, the fact that in Section 539.101 specifies that the eligibility will be at or below 133% of poverty indicates that it is expecting to be able to draw down the federal money for participation in this program or otherwise utilize that eligibility criteria if the waiver is not approved. So I'd like to get to my assumption, a little bit different view that I have, and that is that after studying waivers and attempting to get waivers when I was in the legislature and continuing to research in this field, I don't believe that it is possible to get a waiver that will accomplish what needs to be accomplished. That's why we have been so strongly in favor of a block grant. The underlying Medicaid program must be addressed in order to create the sustainability of the program, of the safety net for the poor. I have much else to say, but I'm running out of time, so I want to point you very quickly to the handout that we passed around, which demonstrates that when Medicaid has been expanded to this population, that it does not achieve what the goals that have been stated, such as lowering the cost and reducing the uninsured. It just doesn't happen. In state after state in the last decade, we saw that the uninsured rate remained basically the same. So there are many, many good things about this bill. We think that it ultimately will, a waiver would not be accepted to give the flexibility that is needed, that a block grant must be sought after in order to do the very things that Dr. Zerwas has put out in this bill. I'm happy to answer questions.
Okay, so this chart.
Yes, there were 4 states that were studied by our sister think tank in Florida, the Foundation for Government Accountability, that over the last decade, Arizona, Maine, Delaware, and Oregon all expanded to basically this same population. And the promises that were made with that expansion were that charity costs would be lowered, that the uninsured rate would go down, and that therefore the state government would be spending less money because they would be spending less GR on uncompensated care. In all 4 of those states, the exact opposite happened. Charity cost went way up. The uninsured rate did not go down, and so the state was, the cost just exploded. The point of that is that there are going to be people who will not insure themselves regardless of what incentives are put out there, what disincentives are put out there. So should our goal be to force people into an insurance product, or should our goal be to provide for care? And I believe that Texas has done much to provide care for the uninsured that is not being recognized, that you all are not getting credit for the money that you have devoted to providing for care for people. And that...
Madam Chair?
Yes.
If I could, so you made a pretty bold statement there about, that the care being provided that maybe isn't being credited for. Could you, what do you mean by that?
Well, in 2003, when we were in our last budget crisis before the dramatic crisis you all faced last time, even though we had a budget shortfall, we committed $10 million for an incubator program for federally qualified health centers. And both the stimulus and especially the ACA have also devoted a lot of money to the expansion of federally qualified health centers. I'm a fan of FQHCs because, first of all, they do one of my favorite things, which is they employ a sliding scale, which I think should be utilized in the services that we provide. But they have a very holistic delivery of health care. It's not only primary care, it's primary mental health, it's dental care, and it's pharmaceutical care, all under one umbrella. And they are provided an enhanced Medicaid match in order to provide services to the uninsured. So we have those. There are programs like Collin County has started a program called Project Access from their county commissioner's court in dealing with their uninsured population. And so in going up to 100% of poverty, they have asked their county physicians to volunteer their time, and that's not only primary care, that's specialist as well. And they've asked their hospitals if they will contribute toward that, and all 10 hospitals have contributed $25,000 toward that program. The county then coordinates and verifies eligibility, and they're doing an amazing job in taking care of the whole range of health services that are needed. So there are models out there that are taking care of folks that do not require Medicaid expansion. And I fear this is too close to Medicaid expansion, that a waiver is going to be denied, and this will.
Okay, so quick question, Madam Chair, follow-up to these charts. Arlene, I've heard you talk about, the Arizona, Maine, and what was the other example?
Delaware and Oregon. And these charts are not complete that I handed out, in that there's a lot of other information in that report.
So I'm trying to grasp, when you say they expanded to a certain population health insurance, that it didn't have any effect on the uninsured, and I'm not sure that my mind wraps itself around that. So explain that to me, because
my mind had a hard time wrapping around that one too, Chairman Colcourse. Let's just take, for example, the Arizona case. They expanded to parents of 10 of children up to 100% of poverty. They expanded to the childless adults that we're talking about. And then they did a small expansion, just a very small expansion into the ABD, age-blind and disabled population. But this was a proposition that was actually passed in the year 2000. And so between 2002 and 2012, between 2001 and 2010, they expanded their caseload tremendously. Their charity cost went up. It was projected, if you can see this chart, the green is what it was projected to be. This is a different chart than what I handed you, I'm sorry. The green is what it was projected to be, and the red is what it actually was, how much the spending was. The hospital uncompensated care increased an average of 9% per year during that time period, and you do have the chart that shows you what happened to the uninsured rate. And if you look closely at that chart, you will see that as the Medicaid population increased, the insurance, those covered by insurance through their employer decreased an almost proportional amount.
Okay, so I'll get with you on these pages because I don't, you know, I see it, but I'm not sure seeing is believing.
I'd be happy to get you more information.
Okay. Thank you.
You're welcome.
So do you have any the why is, I'm sitting here thinking, I know that every church in Denton is out trying to promote themselves and get more people out of their beds on Sunday morning than in churches. Some people just don't want to.
Just don't want to. And when you look at our current uninsured population, you'll see that about a third are non-citizens, and that's both legal as well as illegal non-citizens. And about a third of them make more than $50,000 a year. In that third, you have a lot of what we call the invincibles, you know, the young people who don't think they need any insurance. There's a significant number who make more than $100,000 a year. So it's not just money, although I certainly agree that's the biggest factor is the unaffordability of insurance. But there are many people who are uninsured who have been offered insurance and don't take insurance. It's still a free country so far, and they don't want insurance. I don't know what you do with that, but we're still going to have to provide care. We're still going to have to provide when they come to the emergency room or whatever. We're still going to have those costs, and so are we more interested in having an insurance card in their hip pocket or in providing care? And I opt for providing care for those who aren't part of the system.
Thanks, Arlene. Thank you for testifying. We were doing so good. But you know, I always hate to sacrifice the good at the altar of the perfect. And you had such good things saying about the bill, and I would have thought that maybe Dr. Zerwas had incorporated TPPF's language when we talk about any agreement reached under this section must be made cost neutral to the state. That's wonderful. Leveraging premium tax revenues, achieving cost savings through offsets to the general revenue health care costs, create more efficient health benefit plan coverage options, be designed with goals of relieving local tax burdens, reducing general revenue reliance so as to make general revenue available for other state priorities, minimizing the impact of any federal health care laws on Texas-based businesses. It must be limited in duration and contingent upon continued funding by the federal government. You couldn't have written it better. And this is for the purpose of seeking a waiver. If we don't get the waiver and it doesn't meet these other criteria, are you suggesting we shouldn't even try?
Well, then we fall back to a state-only program, and we have denied the ability to put the people between 100% of poverty and 138% of poverty into the exchange by the terms of this bill. So that's about 260,000 people, and it relies on
Say that again. What are we doing here that you're saying we're including these people in the program? If we don't get the waiver, we're creating a program that includes some people?
A state-only program. Okay, so if you look at section subchapter D, subchapter D in number 1 refers you back to compliance with subchapter C. And subchapter C said 133% of federal poverty. And actually the Medicaid exchange is 138% of poverty, so I don't know, 133, 138. At 138% of federal poverty, then those people, instead of going into the exchange, would be eligible for this program. Sir?
Sorry,
it's about
they would be eligible for both. that would not preclude the eligibility for the exchange if we didn't expand or change the population. They would be eligible for both. That would not deny them the opportunity to go to the exchange.
Well, and the state-only program is paid for by the premium tax, and the premium tax currently goes into the general fund. So this is general fund money. This is not new money. It will be increased by the number of people who will be on the exchange, and so the assumption is that we're going to have a lot more people insured in the state once the health care exchange comes into play. But the premium tax by statute goes into the general fund, except that a quarter, which is about $3 million estimated for the 14-15 budget, but about a quarter of that, or exactly 1/4 of it, is put into the foundation school program, again by statute. So that's that takes away $750,000 of the $3 million that goes into the foundation school program.
Well, we'll get Dr. Zerwas here in a second. I want to walk through this state program, see what exactly this bill does that wouldn't already be implemented under the Affordable Care Act. It's my understanding that this bill simply offers up an option, provided we meet certain hurdles, certain standards, get the waiver, achieve these cost savings, achieve these goals, and unless we meet those, then we're not obligated. So if that's different, I certainly want to hear about it, and thank you for your testimony.
Oh, thank you.
We'll ask Dr.
I wanted to bounce off that, because I think you said if we don't get the waiver, then it goes, and I think there was some trigger that maybe you read, and I've just had the sub for a little bit, but what were you talking about when you first sat down? Just to clarify for me.
In subchapter D, it lays out a state program, and it says if by September of 2014 the Commission is unable to obtain a waiver or other authorization under section the Commission, in consultation with Texas Department of Insurance, shall establish a state program that, number one, complies with subchapter C and is cost neutral and leverages the premium tax revenues.
And you're saying that unrestricted premium tax is not budget neutral. That's basically what you're saying.
Well, the premium tax goes into, by statute, the general fund.
Okay, and I think that's
except for a quarter of it goes to the foundation school program.
That's true. So I think there's a point of clarification on if Dr. Zerwas meant the new premium tax derived from the new exchange participants. And that's a fair criticism. As it's written, it doesn't specify that, but we could talk about that. But
so, are you suggesting that the rub is what goes into the school foundation program, the 25%, or what?
It's a general. I just wanted you to be aware that it is a general revenue. This is the way that this is written currently. It is not. It takes the current premium tax, which goes into the general fund. I have understood, just hearing people talk about the bill, that perhaps that was not the intention, that it was just going to be the premium tax on the new exchange, but I don't believe that's the way it's written.
That was my understanding.
She's right on that, I think, Drew.
Well, we can get clarification and try to address that. That's a very legitimate concern.
Yeah, as I read it, members, I think that point being in subchapter D, it doesn't specify. You'd almost have to create a new GRD, I think.
You're welcome. In closing, I think there were a lot of good things in this bill.
Yeah,
a lot of good principles.
Maybe third sentence. Did you say that you would be in favor if we got a block? Did I hear you say that?
A block grant, yes, ma'am.
So you would be...
Because I don't believe that authority to grant a waiver to do the things that are in this bill. The CMS cannot waive the Social Security Act that creates Medicaid, and we have been told that over and over and over again that we can't do that. We don't have the authority to do that. We don't have the authority to do that. And the problem is that without a block grant, I don't believe it can go this far. So I would like to see our efforts in Texas be behind achieving a block grant to do the very things that Dr. Zerwas has laid out. That's my belief.
Can I follow up on that? Okay. So let me ask you this question. If you're saying that we haven't seen them waive to this extent, but when you're talking about a block grant, I want to clarify kind of like the state premium tax of, is it the new premium tax or the existing premium tax? I want to clarify, when you're talking about seeking a waiver that maybe would give us the money to cover in a block grant, would you be talking about the new Medicaid expansion or the old Medicaid? I call it new and old, existing, expanded, whatever.
Different people call it different things, the old eligibles and the new eligibles and all that.
How that for us in that,
well,
as you're speaking to this bill? I
think that you kind of alluded to it when you started asking questions about Arkansas's deal, which, as Ms. Garamani said, we don't know all the dotting of the I's and the crossing of the T's on that yet, but what it appears to be is no different from what is currently allowed in the HIP program, which is the Health Insurance Premium Payment, which is allowed in both CHIP and Medicaid, which allows CHIP and Medicaid to pay the premium for an employee to get employer insurance. But the state still has to do the wraparound benefit, which makes me think that CMS is treating the expansion population no differently than they're treating the existing Medicaid population as far as eligibility and benefits. So, I mean, if that is true, what we have been led to believe by what's been written about the Arkansas deal, and, you know, as I said, we don't have it in black and white, but it's the HIP program. It allows the purchase of a private sector insurance with the wraparound benefits. So, again, they're not waiving the basics in Title 19 of the Social Security Act, and I think that's what a block grant would allow us to do. I want to be able to do everything that Chairman Zerwas has laid out in this bill. Every bit of it is good stuff. So that's my basic. I don't think.
When Chair Kokos and I were debating on the floor, what was the state you kept bringing up? Delaware, New Hampshire?
The global is Rhode Island.
Rhode Island. You're bringing up Rhode Island, so certainly they do. The CMS has, because that was essentially a block grant.
I don't know.
Well, they call it that.
Yeah, I'm not sure. Boy, I'd have to go back and look at my notes. But
yeah,
they were the only one under the Bush administration that actually, there were a lot of global waivers being sought at the time. We sought one. We were denied it under Bush, the Bush administration.
We were.
And this is what I wanted to bring up, because I think you're right. But the challenge in anything is if you don't ask, you don't get. And the you know, people are saying what somebody will or won't do, and when Florida, Arkansas, I mean, that's what the Arkansas governor wanted. I mean, you know, people make decisions. That isn't what we want. I mean, you know, according to this bill, and I'm trying to say that because each governor asked for what they thought was good for their state. We already have managed care statewide, but they don't in Florida, so the Florida governor asked for managed care statewide. That was a big deal to him. And so there are going to be 29 different states that are going to ask for 29 different things based on what's going on in their state. So I just thought that, isn't that what the Texas solution is about?
As long as it does not tie us to the underlying Medicaid requirements.
Well, and again, it doesn't have to, because the benchmark plans, just like in CHIP, we didn't use the Medicaid plan as the benchmark. We could ask for a different benchmark. It could be whatever the plan is for, what do you call that? You know, each employer plan, the largest employer-based plan in the state. So we could ask for that. We could ask them to waive those other requirements. We could.
Could I follow up on that? And Mr. Chairman, you know, kind of looking at this and the possibilities, you know, of looking at, you know, if nothing happens, it's 100% of FPL and above kind of goes into the exchange. And the more that we talk about the demographics of this particular population, so I think that the effort should be in moving them to that private insurance market in some way or another. I think that the fear is that it's tied to Title 19, and your point is, let's get out of Title 19 and do this in a fair market.
Well, and that's the point. And again, you know,
which I think we haven't been real successful, but I think maybe you could be.
Well, and that's why I signed on to the
President
bill.
Bush.
That's why I signed on to the bill, because, you know, to me, health coverage for people who need it is very important. And if it's done that way, again, I said before in the beginning, then they have access to that health coverage and the use of that health coverage. And if you go back to the 90s, when Clinton put together the first 1115 waivers, the things that we're talking about now are in those waivers. Sliding scale premiums and things like that. This isn't new. I mean, that's what states did when they went to managed care and they used the saving, but they allowed people to stair step in. And the only component they didn't have was the private insurance component. So even though it was in the HIP pieces, but this is different. And I think that each state has shown that what was the most valuable to them in terms of how they would move forward in the shape of their state in terms of health care.
And in 2010, when we did our research on projecting the cost of Medicaid over the next 30 years, I had the researcher to calculate both the cost with Obamacare and the cost without Obamacare to make the point that the underlying system of Medicaid is unsustainable for the long term.
We'll disagree on why it's unsustainable, because I think that there are things that need to be fixed. But, you know, in terms of sustainability, I think it has more to do with providers' willingness to see the population. But if we take the population and put them in private insurance, that's a very different deal.
Well, I think
very different deal.
It is a very different deal, but our research demonstrates that the complexity of the Medicaid program and the inefficiency, the dollars that are spent.
Complex and inefficient. I mean, I'm serious.
Who made it that way?
Yeah.
Well, it has grown.
I'm not trying to be a jerk, but what part of it is broken? If you talk about the eligibility system and you look at the Accenture deal and the fragmentation of how somebody applied, yeah, that was broken. If you look at how the providers have to come and get repaid based on the system, yeah, I think that part of that is broken. But if the system is broken only because there's not a block grant, well, you know, I just don't think that is the definition of a system that's broken or not broken. And I only say these things because we have you passed a bill. We have a lot of control. I've never seen us talk so much like we don't have any control. The only thing we don't have control over, basically, is the block grant.
And I think the block grant is critical to having enough control to streamline this system and to be able to make the most out of our tax dollars that are being spent on care for this population.
So it's a non-starter unless it's a block grant? Is that what you're saying?
I don't believe that we're going to be able to achieve this.
But that's a specific question. Is it a non-starter if the federal government doesn't approve a block grant?
I believe that it is.
For you?
I believe that it is, because I think we
the
will
only
nibble
solution,
around the edges.
You think this is the only solution to making whatever we want to call it, but the existing Medicaid system viable? So
I do, and I can point back to the mid-'90s when we reformed welfare, and that was a block grant system, and we were able to accomplish a lot because the federal government gave us the ability to do that. And the welfare reform had different goals. The objective of the welfare reform was to get people off of the program.
I was joint author of welfare reform, and
yes.
it did work
and
very
it
well.
did work very well.
The thing that we did do is we set a baseline, though. We set a baseline with more dollars for child care.
Mm-hmm.
So we had to up the ability to draw down an appropriate amount of money. And if you ask anybody, we still don't have enough dollars for child care for poor people to go get a job. So, I mean, in terms of the welfare program, it's 17% of the poverty level to get to be able to get in it. Well, why would anybody want to be in it anyway? So, but the deal is whether or not they have health insurance or child care. The point I'm making is that this isn't the same.
No, it is not the same, and I was just about to say that the objective of Medicaid reform is not to take people off of the program, but rather to create a program that is sustainable, that will provide better care, that will provide more options, and that will not destroy the state budget in the process.
Thank you.
Thank you very much.